Hello, everyone. I hope that you're doing well. Welcome back for another RT Test Tip Tuesday. I hope that you're finding these to be helpful. I've got a couple of questions that I'll go over today. Again, with me teaching first and second year students, I try to pick questions that may be beneficial or helpful to those students as they're preparing for upcoming exams or what have you. So we'll stay in line with that. So I've got two questions that I'll go over today. First question I'm going to talk about was good review for my senior students, but more so for my first year students is this some of the content that we're covering in class, and we'll move forward from there. So the question asks, what percentage of arterial oxygen content is extracted by the tissues, assuming the patient is at rest and during normal conditions? So we have to kind of think about the body being and what do we constitute being normal conditions. So this is basically going to be a recall question. We're given percentages that are linked there. So there's going to be some facts and information that we've got to make sure that we can recall. So when we're talking about arterial oxygen content, that is the CaO2. So arterial oxygen content, not to be confused with the CVO2, the venous oxygen content. You do need to, our students, we covered this today, how to calculate the CaO2 as well as how to calculate the CVO2, because you may be asked to for an arteriovenous content difference. And you'll look at the uh, the gradient there, the difference between the two, and sometimes that may clue us in on whether or not we've got issues with our cardiac output. So under normal conditions, we're going to assume that our PaO2 is 100 millimeters of mercury. That would be normal. Our blood gas looks normal, so we'll assume a normal blood gas pH 7.40, PaCO2 40 millimeters of mercury, and PaO2 of 100 millimeters, anywhere between 80 and 100, but for the sake of simplicity, 100 millimeters of mercury. Um, Base excess plus or minus 2, bicarb 24 milliequivalents per liter, SaO2 98%. So those are going to be some of the norms that we're looking at. So when we talk about the content of arterial oxygen, we've got to think about the O2 transport. We also take into account the oxygen equilibrium curve. Now, there's a lot of that you need to understand, but not necessarily specifically for this. So we can start off understanding that at normal conditions, and we'll also take into account that normal condition includes a normal body temperature, so 37 degrees Celsius or 98.6 degrees Fahrenheit. So what do we have to remember? First off, the question is asking about what percentage of arterial oxygen content is extracted by the tissues. So now we think about um, oxygen loading and unloading and so forth. So we know that we have gas exchange that will take place. Uh, so the difference essentially between internal and external respiration. So we know that gas exchange takes place at the side of the lungs for the purposes of loading the oxygen. And when we exhale, CO2 is going to come out. We get the oxygen in through the alveolar capillary network, the pressure gradients that we had talked about last week when we were talking about diffusion. Uh, O2 goes into the bloodstream, increases the PaO2. You have an arterial oxygen content at that point. That oxygen is going to be attached to the hemoglobin and dissolved into the plasma, and that those blood components via the circulatory system get sent down and out to the body where this oxygen now is going to be readily available at the tissues. The tissues within the body need need oxygen, and we need to be able to deliver that oxygen. So we have oxygen delivery that will occur. And under normal conditions, we need to remember in a normal cardiac output, we need to remember that approximately 1,000 milliliters of oxygen, oxygenated blood, is delivered to the tissues. You also need to remember that a normal oxygen consumption, VO2, is roughly about two. So VO2, so O2 delivery, roughly 1,000 milliliters. Need to remember that our VO2, our O2 consumption, going to be approximately under normal conditions, and we've established what those normal conditions are already, roughly 250 milliliters. So oxygen consumption O2 delivery is the amount of oxygen that's delivered to the tissue bed, if you will. The oxygen consumption is the amount of that oxygen that the tissues have taken, or that the tissues are going to utilize. So if we have 250 milliliters that are taken out of that 1,000, then that would mean a couple of different things. So 250 milliliters of the 1,000 milliliters that are available are utilized by the tissues. So that means we have an excess left over of about 750 milliliters of an oxygen reserve. The question's asking what percentage of arterial oxygen content is extracted by the tissues. So we're looking at this VO2, and if we can remember that, so the normal conditions, that's important. If we can remember that O2 delivery is 1,000 milliliters and our oxygen consumption is roughly 250 milliliters, mathematically it works out to where that's roughly 25%. 25 is the correct answer. This is how you can take what you know to apply it to a recall question. And like we said, recall, you've got recall questions, application questions, and analysis questions. Recall are the easiest if you recall the information. And there's a lot of information to be recalled. But you've also been in school for close to 2 years and you've been studying quite a bit. So you should be well prepared. So let me clear this and we'll transition uh, to the next slide that's got the second question on it. So take a peek at this question. This question be yes for my first year students, but in this case, going to gear it more toward my second year students because they're doing board exam preparation, but also they are 5 weeks away from graduation. So for all intents and purposes, they should be able to tackle said question. So we'll look and highlight some of the important things that we have in this question. I'm going to change colors for my pen. Right quickly, we'll go to red and we'll also change the width of the pen as well. All right. So now we're ready to get going. So we have a patient in the ICU is receiving mechanical ventilation. That's important. We have a patient in the intensive care unit receiving mechanical ventilation. The patient's predicted body weight is 52 kilograms. Well, that's fantastic that they give us the predicted body weight. You may see ideal body weight, but maybe more so predicted body weight. But nonetheless, they give that to you. And we know that for establishing a tidal volume, roughly we're going to utilize 6 to 8 milliliters per kilogram of that predicted body weight or ideal body weight, depending upon which one you're utilizing. But in this question, they give us predicted body weight. It tells us or asks us to observe the following ventilator settings and ABG results to provide a recommendation. So we're in assist control, volume control. That's good. We have a respiratory rate set of 15 breaths per minute, a tidal volume of 370 milliliters, a PEEP of 5 centimeters of water pressure, and an FiO2 of 80%. Before I ever look at the blood gas or the answer choices, things that I'm thinking about and processing in my mind already. So, you know, and I know that if you're in a hurry, you may not have because on the real deal test, it's 160 questions and 180 minutes to take the question. So I know you can't spend 5, 10 minutes doing all your calculations, what have you. But there are things that come to mind with this. So the first thing that I can look at is that tidal volume range. Is it appropriate for this individual? So if I grab my calculator, should be around here somewhere, and I'm utilizing 6 to 8. All I'm going to do is 52 kilograms, or it's 6 to 8 milliliters per kilogram of predicted body weight. The patient weighs 52 kilograms. So if I take 52 and multiply that by 6, the low end of my tidal volume is going to be 312 milliliters. The high end of my tidal volume, if I utilize in 6 to 8, 8 times 52 is 416. So 416 milliliters. That's the range for tidal volume that I'm working in. So in order to address a ventilation issue, I would likely need to look at it. I definitely would need to look at the arterial blood gas results, but I'm not going down there yet. I also understand, so my tidal volume is within an appropriate range. I would need to assess my partial pressure of carbon dioxide and look at that to see what it's doing to the pH to decide if I'm going to go up or down on that. The same thing if I were to be asked about a respiratory rate, if I'm going up or down on respiratory rate, would take into account the ventilation component of my blood gas. See that I want a PEEP of 5 and an FiO2 of 80%. Based upon everything that we've gone over and taught, typically when we think about PEEP and FiO2, I'm already in the mindset of thinking, well, I've got a higher FiO2. Why am I not supporting that with a higher level of PEEP to try to help get myself to that optimal PEEP setting for that particular patient, where you're getting the best hemodynamic or the best oxygenation with the least amount of hemodynamic compromise as we're putting that positive pressure in the chest. So just by looking at the ventilator settings alone, I'm already kind of thinking maybe that's the direction I'm going, but I'm going to assess my blood gas now and see what the answer choices are, because it does ask me to review the ventilator settings, the ABG settings, and then provide a recommendation. So I've already assessed the ventilator settings and I have in my mind kind of what I'm looking for, but now let me see if the evidence holds true to what it is that I'm thinking. pH is 7.37. You got to remember your normal values. Quick rundown of those. pH 7.35 to 7.45. PaCO2 35 to 45 millimeters of mercury. PaO2 80 to 100 millimeters of mercury. Bicarb 22 to 26 milliequivalents per liter. Base excess plus or minus 2. SaO2 95 to 100%. So that's where our normal values are, and then we got to remember the relationships. I did an ABG video that you guys can watch if you like. I think I posted that last week, but nonetheless, we'll apply the relationships and interpret the blood gas. So the pH is normal. So let me look at, and my CO2 ventilation is normal. That's in a pretty good spot. Um, the PaO2 is 42. So that's if you look at mild, moderate, and severe hypoxemia, we're not less than 40. So it's not severe hypoxemia yet, but it's just a couple above that. So we're going to find ourselves with moderate hypoxemia uh, with this particular blood gas. The bicarb is on the lower end. If I'm looking at the pH, it's on the lower end as well. Um, and I could see that I likely have a metabolic acidosis, but in this case, call it a compensated metabolic acidosis. Bicarb is down, pH is on the acidic side of normal. But if I look at the compensatory mechanism, if I'm going to allow the respiratory system to compensate for that blood gas, then or to compensate for that low bicarb, then the CO2 patient would probably lead towards a hyperventilation state so that they can become hypocarbic or hypocapnic and drive that pH up to an extent. But the body's able to compensate as is with what we see there. So the glaring issue that we have right now is that the PaO2 is 42 millimeters of mercury, and we do have a SaO2 of 73%, which is lower than what we would like as well. So it's asked me to make a recommendation. So I'm going to go through the answer choices and see which one of these is going to help me to address the oxygenation issue that I have. If I'm decreasing inspiratory flow, um, so you manipulate inspiratory flow to manipulate your inspiratory times or what have you. Um, so if you increase your inspiratory flow, if you increase your inspiratory flow, that's going to give you a shorter I time. If you decrease your inspiratory flow, that's going to give you a longer I time. That could potentially manipulate your mean airway pressure. So while, but I'm not, it doesn't give me what the inspiratory flow is set at within those settings. So while decreasing the inspiratory flow would actually increase my inspiratory time and could potentially give me more mean airway pressure to address that oxygenation issue, I'm gonna think on it for a little bit, but I'm not gonna bite on it just yet. So increase the tidal volume to 400. I have the capability and the range to go up to 400, but my ventilation is okay with this particular blood gas. The issue is oxygenation, so I would mark that out. I don't need to utilize that to tackle it. If I decrease the respiratory rate to 12, a rate of 15 is establishing the pH that I need ultimately to compensate for is establishing the PaCO2 I need to compensate that pH. Um, So again, I'm not needing to address a ventilation issue. So I'll probably mark that out. Now I look at the answer choice D, increase my PEEP to 10 centimeters of water pressure. I go up here, I see that I have an FiO2 of 0.80 and I have a PEEP of 5 centimeters of water pressure. General rule of thumb is once you get to 60% or greater on your FiO2, you need to begin to match that with an increase in PEEP levels. So if I'm looking at what would fix this blood gas or be a more immediate fix to this blood gas, I'm going to choose between A and D. A gives me potentially gives me a greater mean airway pressure, but because my FiO2 is already up, before I get into manipulating I times and so forth to maximize oxygenation, I really like the answer choice of increasing a PEEP to 10 centimeters of water pressure because we're already utilizing a higher FiO2. Manipulating I times to maximize your mean airway pressure are certainly things that you can do, but in this case, the best answer choice is going to be to increase the PEEP to 10 centimeters of water pressure. Thank you for your time and I hope you have a good day. Join me next week for another RT tip.